I want to start out by just welcoming everybody. My name is Wayne Weber. I'm Dean of the College of Business, Industry, Life Science, and Agriculture. And as we know, there's been a significant demand for accurate and accessible information regarding the coronavirus, vaccines, and vaccination as mobilization continues to roll out across the tri-state region. And tonight, we hope to provide a venue to access that information to the extent possible through our esteemed professional panel. And so on behalf of the college and university, I'd like to welcome and extend our appreciation to our panelists for sharing their expertise. We also want to extend our appreciation to our audience for joining us. And to get this started, I'd like to introduce our colleague and our host, Dr. Rich Dianchin. Dr. Dianchin has a medical doctorate degree with a background in community health and has been on the faculty at UW-Platteville for over 10 years now. And so we welcome Rich as our host. And Rich, please take it away.
Well, thanks, Wayne. And again, thanks to you all that are in attendance for joining us tonight. And so we do have a pretty nice turnout. And so it's great to have so many people interested in learning more about what we have to say. And I will assume that you all aren't here just seeking extra credit. But if you do need a couple points, just send me, I don't know, bank account and I'll deposit it there, a couple points. So a couple housekeeping items that I wanted to share with you guys first. We do welcome your questions and we'll try to do our best to answer them based on the panelists' area of expertise. That said, we won't be specifically addressing audience questions until after our initial presentation and discussion. So hopefully we'll answer a lot of the questions just in the course of the presentation, but we hope to make sure to have sufficient time to answer ones later. For asking questions, you should be using the Q&A button that you find at the bottom there. So you can type the questions into there, and then my colleague, who is off to the side somewhere, Dr. Amanda Trewin, is going to help feed those questions to us later as we kind of work through stuff. So also, when you're submitting a question, there will be a box that shows up that'll allow you to do it anonymously if you'd like, and you can just check that box when submitting it. So we really appreciate your presence and thank you in advance for civilly engaging with us tonight as we try to deliver some useful information. When you registered, you were able to see the bios of all of our panelists, so I'll be real brief here as I introduce them. So first, I'll start with Dr. Ryan Hassel. Dr. Ryan is an evolutionary geneticist and associate professor of biology here at UW-Platteville, and he earned his PhD in genetics from UW-Madison. So thanks for joining us, Ryan.
Thank you.
Next, Jeff Kindray. Jeff is the Director of Health Service and Health Services Officer for Grant County Health Department. He has more than 27 years of experience working in public health, holding additional positions as an epidemiologist, sanitarian, environmental hygienist, and to be blunt, he's had a busy year. So thanks for being here, Jeff.
Thank you.
Next, Dr. Chris Main. So Chris is an associate professor of biology at Viterbo University up in La Crosse. Chris is also a UW-Platteville biology alum that got his PhD in genetics after Platteville at UW-Madison. He then completed some postdoctoral fellowship work in immunology at Medical College of Wisconsin. Thank you, Chris.
Thanks, Rich.
Dr. Lauren Priester is an assistant professor of biology at UW-Platteville. She is the youngest member and the newest member of our faculty, I should say. So she earned her undergraduate degree in microbiology from Michigan State University, go Spartans, and her PhD in microbiology from Northwestern University, where she studied bacterial genetics. Thanks for being here, Lauren.
Thanks.
And next, while Dr. Mike Roy is now retired, he's still very active in the scientific community. He spent 50 years in infectious disease with 30 years developing vaccines for federal government agencies, academia, foundations, biotech, and pharmaceutical firms. He is another UW-Platteville alum, and we're thrilled to have him join us. Thanks for joining us, Mike.
Thank you for having me.
And then our final panelist is Dr. Jeff White. Jeff is a family practice physician with Medical Associates in Platteville, and he's originally from Oregon, but has been in our community since 1997. So thanks for taking the time to be with us today, Jeff.
Thank you.
So to kick us off, today marks a year since we adopted the sweeping measures to deal with the coronavirus pandemic. We implemented widespread shutdowns to mitigate the spread of COVID-19 and flatten the curve to decrease the burden on our local health care systems. I mean, I'm sure that a lot of you, just like, there's that, where were you when, 9/11 happened? I mean, I think we can all remember where we were and what we were doing when we were told to go home and stay there. And so locally, our initial cases were low, with the greatest impact being in nursing homes. Cases spiked significantly during the fall and have since come down. So to get us started, I'm going to talk to our physician and our public health officer, the two Jeffs on the panel, which will make it interesting for me to ask questions. And you each have different focuses, with focus on working with individuals versus working with the general public. And obviously there's overlap in what you do, but I'd like to get your take now on how we as a community are doing with COVID. So starting with Jeff White, what are you seeing in your patient population with regards to positive cases and, more importantly, sick patients right now?
Yeah, cases are definitely down. I personally haven't had a patient with COVID in the hospital in probably 3 to 4 weeks. Positive cases are rare. We're managing the vast majority of them as an outpatient. So locally, for me personally, it's been quite a bit less than when we were at our peak, which was quite busy.
Okay. Yeah, and so that leads us to asking about the peak then. So what was it like at its peak for you and your colleagues? And colleagues could be more broadly, not just locally, if you want.
Mm-hmm. Well, we have a separate clinic here that we built when COVID hit to triage patients, and that clinic was run by whoever could go see patients over there at the time, and it was a lot of running and a lot of coordination. In the hospital, there was a separate wing that was separated off with plastic and negative pressure and so forth. That we don't have an ICU because we're a small hospital here, but we had negative pressure rooms and dedicated nursing staff, and a lot of procedures for the sanitization and so forth that were being followed. Yeah, at its peak, I probably had 2 or 3 patients in at a time myself. And there were times when the hospital had to expand its ability to take care of the patients but not for a very long period of time. Nothing like what you read about, the nightmarish scenarios in larger cities, luckily.
And you're referring to Southwest Health Center and Platteville, right? Yeah.
Right, that's right.
Okay, now I'll switch to the other Jeff. So how would you say that we're doing as a community now, Jeff?
Well, currently we're doing pretty well, actually, but there's still a significant amount of activity going on. If you look at the state metrics, they still consider us to be at high levels of activity, but any day now I'm expecting us to drop to moderate. We're averaging about 4 confirmed cases a day, under 4 confirmed cases a day. We're averaging less than 2 probable cases per day. And back at our peak, our biggest peak, because there were several, in November, we're averaging over 100 a day. And that was very challenging to try to follow up both with the positive cases and contact tracing that comes with it. So it's quite a difference. For us to get to a low level of activity, as the state would see it, we need to average about a case every 3 days or so. So we've got a ways to go from there. We're about 10 times higher than low. So we're working on getting down there. But our vaccination efforts are truly putting a dent in things. And we're seeing much less cases in our 65 and older at this point. So in the past 14-day average, we're really only seeing 2 to 3 cases in 14 days that are 65 and older. So we have seen a significant improvement in those age ranges.
Okay, that's excellent. Yeah, and so I mean, looking back, we're looking like, what do you think are some of the places where we've probably struggled the most at the moment?
Yeah, so early on, clearly our nursing home settings were a struggle all across the country, and in Grant County was no exception. Right now, since we're doing well, we're seeing things pop up in different age ranges. A while ago, we were having problems in our schools a bit with school age kids. More recently, it was 50-year-olds. Now it's 20-year-olds and younger that we're starting to see peak up a little bit. And we've had issues in different areas of the county. So the southern part of our county is a little bit more active than the northern part. One thing people got to keep in mind, though, is that testing is down significantly. So we are missing some cases, but clearly the hospitals are doing better. As Dr. White had indicated, he's seeing less patients. So the reduction is real, and we're doing better in many areas. But we're still having some problems with compliance with masking when you're around others, some large gatherings that we'd rather not see happen quite yet. We're getting ready. There's been a lot of new guidance coming out, which I'm sure we'll get to.
Yep.
But those are things that we could use a little improvement on.
Okay, well, great. Thank you, Jeff. The other thing that I know that people have been seeing, and you see it, you saw it months ago in Australia, even flu cases are way down. Flu cases are way down this year. And so what can you, Jeff Kindre, can you speak a little bit to that? I mean, what would you say are the reasons behind that?
Well, I think there's lots of reasons behind that. Flu immunization rates were still fairly high, which is good. I think people heeded the warnings that you didn't want the dual infection of both influenza and COVID-19. So our flu vaccination rates were pretty good, considering even the challenges in getting in to get your immunization. I think they're social distancing. People are following that. There's masking and improved hand washing, particularly in schools. And we think in epidemiology that kids transmit a lot of flu through the schools, through their interactions with each other. And then there's been less travel, and we're a global society now. So if there's less travel, there's less exposure, and there's less cases elsewhere. So therefore, there's really less cases here. And that extends beyond just influenza. We saw probably about a 40% reduction in overall vaccine preventable illness and a reduction in STDs as well. But they were replaced with about 28,500 reports of COVID-19 illness alone in 2020, which is just unbelievable and completely remarkable that we had to follow up on all those cases when we typically get 800 cases of all diseases in a year. And then since December 31st, obviously we've gotten more as well.
Thank you. Yeah, and I definitely agree that my kids, while they provide tax write-offs, they also are disease vectors. So I'm gonna throw that question about flu to you, Jeff White, as well. What are you seeing with regards to flu and other vaccine preventable illnesses?
Yeah, definitely less. What in primary care, what we tend to see is we see the flu, of course, but a lot of people take care of the flu by themselves at home and don't see the doctor. What we end up seeing are sinus infections and pneumonias that are consequences of flu, where secondary bacterial infections can hop on, or viral pneumonias themselves are very common. And so we've seen a pretty significant drop in those as well, as far as I can tell. And talking to my colleagues, they've been seeing that as well. Another interesting phenomenon that I just read about and didn't experience personally, but I know the South, which tends to get their flu season a little later, had a significant drop in flu cases earlier this year. They tend to get their flu cases in April and May sometimes, and they hardly had any flu either. Again, probably because of what Jeff Kindre was saying with the mask wearing, social distancing, hand washing, adherence, all the decreased travel, all that. So yeah, we're definitely seeing less flu here. I can't say I've even diagnosed one case this year, and I've usually written multiple prescriptions for Tamiflu by now.
Oh, okay, thank you. So we already mentioned this, and you mentioned about hospitalizations being down now. So do you think this is mainly due to, I'm talking about COVID hospitalizations here. So do you think this is mainly due to prevention or better understanding how to treat patients? Do you see any changes in patient treatment now versus what you were using treatment-wise, back when?
Oh, the answer to that question is pretty complex because there's a lot of factors that go into it. As Jeff was saying, there's quite a few patients that have had COVID-19, which does give you some level of protection. So there's that group. And then there's a large group in Grant County that's been vaccinated, which is definitely helping already, I think. The 65 and above in particular, starting with the nursing home population and then others. And then as far as treatment goes, there have been some successes, I believe, in treatment where in particular, the monoclonal antibody treatment that you hear about on the news and so forth, both before somebody goes to the hospital or while they're an outpatient, in addition to monoclonal antibody treatment in hospitalized patients, has advanced and been shown to be fairly effective. Interestingly, remdesivir, which was the big drug to get in the beginning of all this, has started to fall a little bit less favorable. We just aren't seeing quite the results by itself. Although if you combine that remdesivir with another monoclonal antibody that's actually a pill, it seems to work quite well. So it's sort of interesting what we've learned over time with regard to treatment in the hospital and as an outpatient. Outpatient treatment, frankly, is largely supportive, but the infusions that people have gotten prior to, or when they're diagnosed initially, especially if they're in high risk groups, have been helpful in reducing disease load, we think, and has also reduced hospitalizations. And that, luckily, because we live in a smaller community, has been fairly readily available to most patients who we've ordered it on, at least at our clinic. We haven't had any major hurdles getting the medications. So that's been very good.
Excellent. So I'll stick with you. As you're seeing patients, what are their biggest concerns right now? What are some of the biggest complaints and concerns that you're hearing?
With regard to COVID-19 is, when can I see my grandkids, and when can I get back to normal? That's by far the biggest concern. And also, what about this vaccine, and is it safe? And and the statistics being what they are, it's always a little foggy, but I know I would say roughly maybe a third of patients are skeptical about getting the vaccine. So I have a lot of conversations with patients who are skeptical, as to the merits of the vaccine and why they would want to do it. Not everybody is convinced after I'm done with my, discussion, but hopefully a few folks have changed their mind and gotten the vaccine. So the biggest challenge right now for people is everybody's up to here with the restrictions, and they just want to get on with life.
Mm-hmm. Have you seen any issues with like the whole long haulers situation? And
yeah, that's been interesting. COVID pneumonia is a funny animal. It's a strange pneumonia. When you look at a chest X-ray with somebody who has COVID pneumonia, it looks almost like they have little packing peanuts inside the lung. It's just this strange looking pneumonia, very distinctive, similar to when we had SARS, which was quite a few years ago. But I'm old enough to remember SARS pneumonias. What's interesting is they don't really resolve in terms of the radiographic findings right away. And I've had a few patients that have had some very late secondary bacterial pneumonias after having COVID pneumonias. The post-COVID syndromes that are starting to we're starting to see more and more research with that is also, we're learning more about it as we go on, and all the neurologic manifestations and the chronic fatigue syndrome. It's to me, this is just me speculating here, but it seems a lot like mono or other illnesses where you just continuously have to fight the viral, syndrome for months at a time in some people, and other people, there's no symptoms. So it's such a huge spectrum of response to the organism. So
Yeah, fascinating.
we're learning as we go.
Yeah,
That's for sure.
yeah. It's as a person involved with science, it's exciting, but also obviously, frustrating and scary. I'm going to go back to Jeff Kindry with this next question. So in the last few days, and this kind of gets to what Dr. White was saying about people just kind of being, fed up with things. And so in the last few days, the CDC has offered some new guidelines on fully vaccinated individuals. Can you comment a little bit on how this will affect us in Wisconsin at the state and local level? And I think there are some changes here already, right?
Yes. I will. And one thing I'll just mention first is that we wrapped up our 2019 needs assessment for Grants County in August of 2019. And one of the things we identified was social isolation. And clearly, COVID has not helped us in that trying to address that issue with everyone having to stay at home and forego visiting. So it's something that was a concern to us pre-COVID and became a bigger concern as we worked through COVID. But just recently, the CDC came out with guidance for fully vaccinated individuals, which is starting to indicate that we're going to see an opening and a relaxation of some things. People still have to use some caution out there, but visits with other fully vaccinated individuals indoors can be done without masks and without social distancing now. And by fully vaccinated, we mean completing the series. If it's a 1-dose series, it's 1 shot plus 14 days. Or if it's a 2-dose series like Pfizer or Moderna, it's after the 2nd shot and 14 days. So your body has time to develop the full immunity. Other things that you could do, according to the CDC, and we fully expect the state has indicated they've are going to adopt this and update their guidance on their website, is visiting with unvaccinated persons from a single household, provided that everyone's healthy and there's no high-risk individuals involved in the visit. And then it also allows you to be refrained from quarantine if you're exposed to a person, as long as you remain without symptoms and are healthy. You would not have to go through quarantine. Originally, there was like a 90-day window after vaccination. As they learn more about the vaccine, they've lifted that 90-day window. So there is no time frame on it after you're fully vaccinated. The other thing I'd like to point out is CMS or Medicare just came out with new visitation guidance for nursing homes, which a lot of people have concerns about visiting in nursing homes. And although the state regulates nursing homes as well and has to go through the guidance, I expect that a relaxation in visitation in nursing homes is in the very near future as well.
Great. Thank you. That's good news. So we're going to switch now and change our focus. And so let's shift our focus to talk to some of the scientists that we have on the panel here about the COVID-19 virus and then the vaccines that have been developed. To kick us off, we'll start with Dr. Lauren Priester. And I realize we've all heard a lot about COVID already, but while we've all learned a lot, I think as a teacher, I always think it's important to review a little bit. So I'm going to ask Lauren, if you can please share a little bit about COVID-19 and what it does. And I do have some slides here, correct? So let me.
Okay, thanks, Rich. So I just wanted to give a little brief introduction to COVID-19 and the virus itself, which is called SARS-CoV-2, because as we heard, it's related to a previous virus that caused an epidemic years ago. And so the virus is called SARS-CoV-2, and it's shown kind of at the bottom of the screen. And viruses are these tiny, tiny little particles that you can fit hundreds, if not thousands, in a single cell in your body. So we're talking incredibly small. And this virus is a very simple thing. It has a genome, and that genome has its genes in it, just like our genes. We have a genome with our genes in it. And this genome is actually made of RNA, which is different than in our bodies. Our genome is made of DNA. And the RNA is less stable, so it gets packaged in this thing called an envelope. And on the outside, it's made of lipids and proteins, so kind of an oily protein substance, and that protects the virus. And what's important about viruses is they can't copy themselves unless they're living inside of a host cell. So if I get sick, the virus can copy itself inside of me, and then I sneeze on my neighbor, and then they can get the virus and it can copy itself in them. And so this protein coat on the outside protects that virus, and then it can attach to a host cell and get inside of a host cell. The SARS-CoV-2 virus attaches to mucosal surfaces. So think of moist surfaces such as your eyes, your nose, your throat. And once it gets inside, it's going to copy its genome and make more of its coding. And that's basically all it does, but it can make lots of copies. And once it makes lots of copies in one cell, it can leave that cell and go to the next one. And it'll do this again and again and again and infect more and more cells as it gets inside of our bodies. And as you think about how you inhale, the air brings the virus potentially deeper into your potentially lungs. It can grow in your nasal pharynx area, so up in your nose and throat. And it can also leave when you exhale. The virus particles can leave your respiratory tract and travel somewhere else. But as it infects more and more cells, what stops it is our immune system can detect it and say, hey, there's something foreign here. We need to get rid of it. And so sometimes our immune system does that pretty quickly and it doesn't infect very many cells. And so you may not even know that you got sick. You may not even know that you had the virus, but sometimes the virus can keep infecting more and more cells and spreading. And that can cause more severe disease. And then you're also probably expelling more and more virus. Sometimes the immune system also is trying to get rid of the virus. And instead of just getting rid of the virus, it becomes overstimulated. And we're seeing that with this virus too, where the immune system turns on too much and gets too activated and actually causes damage to different organs and different parts of the body. And so that's something that we heard about from the previous talks, and you've probably heard about in the news. There are people who are asymptomatic and there are severe cases. We don't always know how someone will react to the virus, but we do know that some of these severe cases are in people who are older, and that's usually because the immune system doesn't function quite as well as people age. So that is your mini COVID lesson.
Thanks, Lauren. So the next question, I'm going to go to Dr. Ryan Hassel with. Ryan, we hear a lot about spike protein. So why is the spike protein in the center of so much attention?
Yeah, so when you, as Lauren was indicating, when you take in, unfortunately, viral particles of SARS-CoV-2, the first thing that it needs to do in order to, screw your life up and screw your cells up is to actually gain entry into the cells, as we saw in the previous slide. So the analogy that I came up with that I'm sticking with is that you can think of the spike protein, which is named so because it's the spiky thing that's coming outside of the membrane that Lauren described. You can think of that as the key So a physical key, in the analogy has a particular pattern that matches a particular lock, right? And if SARS-CoV-2 is going to gain entry into one of our cells, it has to make its way through the only gate that allows it through. And even that gate is sometimes closed to it because the pattern of the key, the spike protein, needs to match the pattern of amino acids, which make up proteins, are the building blocks of proteins, has to match the amino acids that we find at the tip of the ACE2 protein. So the ACE2 protein is not a viral protein. That is sticking out the surface of some subset of our cell types, right? And so if these barbarians at the gate, if these viral particles want to get in and wreak havoc, right? And obviously they're not thinking things, but if they're going to get in and replicate themselves, make copies of themselves, they need to have a match, and they need to find entry through ACE2, the gate, if you will. That very bottom graph, or illustration, which looks rather complicated, that is showing the interaction between the spike protein at the very top, and then on the bottom, certain parts of the human ACE2 protein sticking out of our cells. And in the middle, in the white there, you can see that some connections are being made, right? So this would be a case where the pattern of the key is able to unlock the gate. And this raises the issue of, where did this virus come from? Why did it suddenly start infecting humans? Well, most likely up until mid to late 2019, this virus was in a non-human species, most likely a bat, right? And mutations occur to nucleic acids like the RNA that's inside of this virus all the time. There are errors made when the virus is copying its genome that Lauren referred to, right? And so those errors sometimes are going to change the pattern of the key, right? And so what could previously only infect a bat, right, now has the ability to enter our cells. So the key has been changed. It now unlocks human cells. It got into a human. It proliferates within the human. That human passes it on, right? And that is the gist of the spike protein, right? It is the key to getting into the human cell.
And like you were saying, Ryan, with RNA copies, it doesn't copy that well, right? It's not terribly good at making copies. It makes a lot of mistakes sometimes, and so you get more of these kind of mutations. Is that correct?
That is correct. So one of the proteins that the viral genome codes for is what we call an RNA-dependent RNA polymerase, which simply means that it takes RNA it reads RNA and makes an RNA copy. And you're exactly right. So like DNA in humans, a single nucleotide has about a 1 in 100 million chance of mutating. It's a couple orders of magnitude higher for RNA genomes.
Okay. Thanks, Ryan. So I'll stick with you, and now I'll ask you a little bit about the differences between the vaccines that have been approved, and I think I do have that here.
I think there's one more slide. So I won't visit this overly much because I believe Dr. Roy is going to address this in some more detail, and I'm certainly not a vaccine developer or anything. But the two vaccines that were approved for emergency use by the FDA back in mid-December, one week after the other, so the Moderna and the Pfizer vaccines, what is common to both of those is that on their interior, in the interior of the vaccine, are RNAs, messenger RNAs that provide the information to produce the spike protein, which is another reason it's important because it is the thing that we're trying to get our immune systems to target. So at the very top in that picture up there, you see the vaccine itself. So the rectangle is surrounding a copy of the information to produce the spike protein. And then the exterior of it is nanoparticles of lipids. And basically what you see there, lipids are fats. Most of them are properly categorized as fats. And it's similar to what makes up our own membranes that define our cells. It's different, but it's similar. And both of these vaccines, again, have messenger RNA in them. So that distinguishes them from the third one, which I'll talk about in just a second. Okay. Both of these, as probably most of you know, do require 2 shots. And one of the problems, particularly with the Pfizer vaccine, is the stringent requirements for storage. RNA is much less stable, particularly in environmental conditions inside the body, inside the cells, than DNA is. And so that is one of the reasons that ultra cold storage is necessary to protect that precious load of RNA in the middle. And so that's a big problem. Moderna improves that somewhat, but really what's incredible about these vaccines is just the level of efficacy, right? So the fact that both of them are kind of on the 95% efficacious, they're 95% efficacious, is absolutely remarkable. And one of the things that I would, compared to like the seasonal flu vaccine, which sometimes is as low as 10 to 20% effective depending on the season, right? But this didn't just happen out of the blue. We were fortunately well prepared to develop, or the people who did develop these vaccines based on decades of scientific research. And so I think this is, just a classic case to suggest that taxpayer-funded research is something that we should be happy to spend some money on, because of the fact that if you don't, you can be caught, unprepared. It's not like everything works out perfectly. All science doesn't go somewhere, but in this case, that background knowledge has really helped. Finally, the Johnson & Johnson vaccine, which was approved at the very end of February, may be a game changer. Others can speak to that more so than me, in that it's just 1 shot. It can be stored for long periods in the refrigerator, and there are no allergic reactions. This differs from the other 2 vaccines in that there's double-stranded DNA for the spike protein in the middle, and so it requires a little bit more work for our cells to produce that viral protein. And the efficacy is a bit lower, but it's just 1 shot, and you can, it's much more stable. The other difference, and this is the last thing I'll say before I pass it off, the thing that is surrounding the DNA in the Johnson & Johnson virus is an adenovirus, hollowed out inactivated virus, right? And so this may explain partially why there have been no allergic reactions. One of the concerns with Pfizer and Moderna is the inclusion of polyethylene glycol, or PEG, in that coating. And that does have there have been some papers that have come out that have suggested that increased anaphylactic shock, which is still super rare, but slightly elevated relative to other vaccines, may be due to the inclusion of that PEG. So that's one important thing as a takeaway, is if you know that is something that you've been allergic to in other medications, it may be worth discussing that with your doctor more. And
Thanks,
that's all.
Ryan. Yeah, thank you. Lauren, do you have anything to kind of add about vaccine development at all? Or...
I'll just add a little bit that I agree with Ryan that these have been really amazing examples of how science can move really quickly when there's enough funding. And mRNA vaccines have definitely been researched for at least 30 years now. And so this isn't a new idea, but the fact that they got that genome sequenced right away when we discovered this new virus, and then they were able to immediately make these vaccines and start testing them. I think they started testing over a year ago now in humans for the Moderna, at least, and probably all of them around that time. And so the production is really quick now that we're able to manipulate the RNA and the DNA this way. And so I think this is a really promising future for vaccines in general.
Yeah, thanks, Mom. So next I'm going to switch over to Chris. So I'm going to bring Chris Main to talk a little bit about some of the myths surrounding the vaccines that we've been hearing. So let me, is this where you want me to be?
Yeah, that's perfect. Thank you, Rich.
Yeah.
So this is actually just sort of another representation of what Lauren was showing earlier, which was showing the way in which, or actually what Ryan was showing earlier, which was showing how these vaccines work and how they get into the cell, and then what sort of happens then to activate the immune system. And so you can again see this mRNA to the spike protein. And the one little point about spike I'd like to make too, to add to all the great things that Ryan said, was that spike is actually what our immune system naturally targets. So people who have recovered from COVID, we will be looking in those individuals to see if they raised an immune response by looking for antibodies to spike. It's the number one thing to attack. And so that's why it makes sense that that's what we make the vaccines out of. Also, by targeting that spike, that means we limit the ability for the virus to try to evade our immune system, because it's also the key it uses to get in. So it can't change that key too much. And so one of the things that's key to remember about these mRNA vaccines is that mRNA is very fragile, just like Ryan said. In fact, it's probably kind of something that's funny to those of us who have done bench science on the panel, because it's sort of the bane of your existence as a scientist to try to do stuff with RNA, because it just will fall apart if you look at it wrong. We have enzymes all over our body, all over the environment, that just chew them up. And so this lipid coat helps to protect them from degradation. But no matter what, they're pretty short-term things. They don't exist in our cells long. What exists longer is the fact that we make these proteins and then raise an immune response to it that gives us memory. So that lipid coat protects them and also helps them then get transported to the proper areas. So they don't just only hang out in the muscle of the arm, for example. They go into the lymphocytes, or they go to, lymphatic vessels, to then go into our lymph nodes, where they can encounter the proper immune cells to actually raise an immune response. So as far as some myths go, there's so numerous ones, that I probably don't know all of them, but I'll share with you some of the common ones that people ask me about. And one is actually the fact that people will say that the vaccines could change your DNA. And so the reason that this one actually doesn't make a lot of sense from a scientific perspective is, right, remember they're RNA. And like Lauren explained to us, our genome is DNA. The virus has an RNA genome. Not only that, the RNA is very fragile, short-term, doesn't exist very long. So we would have to have some way for that RNA to not only get into our cells, but then to get into the nucleus, which it doesn't go to. We'd actually have to have a way to turn it into DNA, which takes an entirely different enzyme that these vaccines don't have. And then we'd have to find a way to stick that into our DNA, which again takes a whole nother bunch of molecular machinery that the vaccine doesn't have. And so because this is an mRNA, it really can't integrate into our DNA. The second most common one I've heard, and I teach at Viterbo University in La Crosse, and so I teach a lot of young folks, and we're a very skewed nursing school, so a lot of young women too. And one that they've certainly heard about and asked me about is these vaccines can make women infertile. And so first I'd like to kind of touch on, I think, the basis of where they try to take that and then kind of bad actors can lead it along, right? Is that the sequence of spike has a few amino acids, and we're talking like a handful, I think it's 5, that are the same as a protein in the placenta. Now, you could imagine thinking, wow, it's got these amino acids that are the same. And remember, Ryan told us that amino acids are the building blocks of proteins. That if these amino acids are the same and we vaccinate against those amino acids, could that cause damage to the placenta? However, that's actually a ridiculously short number of amino acids to have the same. That's going to happen hundreds, if not thousands of times in our body. And for that reason, our immune system doesn't actually respond to such tiny short strings of amino acids. One of the things that I did for my job is I made sort of immune responses that were directed, and it always took at least 13 exactly the same all in a row. And so that's way beyond. Now, what's perhaps even more meaningful though, is that we know that these don't cause this because of the clinical trials and because of the number of folks who have gotten vaccinated now. So when they ran the clinical trials, they intentionally did not enroll women who were pregnant, right? We try to generally keep those folks protected from any new experimental medicines. However, many women were pregnant when they enrolled and they didn't know that. And they went on through this trial and they went on to give birth to healthy babies. Additionally, people got pregnant during the trials. That's even more people that happened with, cooped up in the house, I guess. Then also, we know now, right, that these vaccines have been given to millions and millions and millions of people, right? And we're not seeing this happen. And so there's actually sort of a deep history of this, that oftentimes this myth will come back. And it's not only been for mRNA vaccines, it's been around for lots of vaccines throughout history. We're talking like hundreds of years, like back to like original creation of vaccines. So it's a deeply historical thing that kind of keeps coming back. I think probably because it's effective. It's an effective scare tactic. And Ryan also mentioned the polyethylene glycol, PEG. So that is something that we need to know is in there. And if someone has had a severe allergic reaction to it before, that we need to then watch out. But it is a super common molecule. It sounds kind of scary, polyethylene glycol, but it's in ice cream. It's in toothpastes. It's in laxatives. So pretty much all of us have been exposed to it before. So it's not some sort of brand new chemical that's in these either. I think that's pretty good for now, Rich.
Thanks, Chris. So now I'm going to bring in Dr. Mike Roy, and I'm going to share my screen in a second. And Mike's going to speak. He's been doing a lot of kind of talks about this and reading about this and research on this. So he's going to share a little bit about the risks and benefits associated with the disease and the vaccinations. So let me share again. Oh, wrong one, sorry. There we go. Okay, Mike, are we in the right place? Oh, you're still muted, Mike.
Yep. My memories of vaccination go back to 1955 when I was in a line like this receiving a polio vaccine. My parents made the decision because I was a minor, and they based that decision on whether or not I would get the vaccine on risk versus benefit. Today, I, along with the rest of you, need to make a decision whether or not we're going to get vaccinated with a new vaccine, in which we're in a new pandemic. In the next slide. And that is one of the vaccines that Ryan discussed, a Pfizer, a Moderna, or a Johnson & Johnson vaccine. We probably won't be offered a vaccine that is currently in clinical trials, at least not until later this year. Those are the Oxford vaccine, the Nova vaccine, and I doubt if any of the vaccines that have been developed in Russia, China, or India will be used in the United States because those countries are focused on foreign markets. And the next. We're going to make this decision ourselves with a little bit of thought, and we're going to make it based, just like my parents made that decision for me, on risk to benefit. Does the risk outweigh the benefit in my mind? And in the next one. And so we're going to look at risks in the next few slides. And then in the last slide, we're going to look at the benefits. And the information I'm going to give you is taken from peer-reviewed scientific literature that's come out recently. And we're going to look at risks and benefits in pretty much the same way that the Food and Drug Administration, advisory committees, and so forth look at what are the risks of these vaccines, what are the benefits. The risks is listed on this slide are, first of all, expected reactions. You might say, well, those aren't really risks. Those are expected, but we put them in the category of risks and or unexpected medical events. We'll talk about those in the next couple of slides. There are also unexpected issues that occur with vaccines, and these generally cause us a little bit of concern because they come up in the press. First of all, manufacturing issues. We've already seen at least one issue come up. There's been a delay in delivery of vaccines because a couple of the companies have had problems in manufacturing. These aren't safety issues. This just says that the company has caught something that needs to be changed. They're going to take a minute to make sure that they're manufacturing correctly or that they can make enough of the material in their manufacturing. The other are quality issues. These oftentimes come up and with any drug, not just with vaccines, in which there's a report, sometimes proven true, more often not, that there's a problem with the quality of vaccine. And this usually almost always just simply affects a single lot or batch of that vaccine, but it leads to a halt in the vaccination process or the distribution of vaccines while that's investigated to make sure that it isn't a real issue. Other issues that may arise in the future are this possibility of a drop in efficacy. We know that after we vaccinate, we get very high immune responses, but today we don't know how long those the responses to the vaccines are going to last. And so this, some people consider a risk because it's a bit of an unknown. The other question we haven't answered yet is, what if we get our first dose and then we wait 3 months to get our second dose? What kind of effect is that going to be? With other vaccines, we find that it has very little effect on the efficacy of the vaccine, but we really don't have any data, any hard data yet on that. Emergent strains are going to be discussed. Emergent strains are a real risk. We've seen it in the newspaper. What if I get vaccinated and then I run into an emergent strain? The data to date suggests that we may not have the efficacy from our current vaccines for certain emergent strains, but we will probably have some efficacy, and it may be pretty significant. But we don't know what the future is going to bring. And then with vaccines, like all medications, there's theoretical issues, and you're going to see these on the street, in the press, on the web, and so forth. They're going to arise. In the next slide, we've already looked at what the results of the clinical studies are. Very large clinical studies, in my estimation. A lot of people were enrolled, almost 100,000, mostly in the United States. The neutralizing antibody responses, which is what we believe is going to protect us, were very high, surprisingly high, very good. Protection from infection, and there's a mistake in the Moderna, it's 94%, not 100%, has been unusually high. In my experience with vaccines, there are only 2 vaccines that have ever reached this level of protection. This is extremely high protective efficacy. And the adenovirus has a very high efficacy as well, beyond what we expected or hoped for. Protection against severe disease is especially good. And the last reports that I've seen, the last published reports, suggested that there have been no deaths in those 5% of the people who do in fact get vaccinated and then develop an infection. So it's very protective against death as well. We're going to talk in the next 2 slides about local and systemic reactions. We've seen some adverse events as well. with anaphylaxis or allergic events. They've been very low. We see anaphylaxis and allergic events with just a large number of drugs and also with vaccines. And this is being monitored pretty carefully. It's the reason that you're asked to stay for 15 to 30 minutes after you've been vaccinated, because we know that 72% of these events occur within 30 minutes of vaccination. And when you stay in the vaccine clinic, you're with medical personnel. You're within help if something should happen. But these have been extremely rare events. I think 118 total allergic type events or anaphylactic, the combination out of the first 4 million vaccinees with a Moderna vaccine. And the next slide. This is a busy slide. I apologize, but this answers the question I get asked most. The question I get asked most by my friends and colleagues is, how likely is it that I'm going to have a reaction on my arm or in my body in general, systemic, after I get this vaccine? And the answer is on this slide. At the bottom of the slide, it says that 65 to 85% or 80% of COVID-19 vaccines are going to sense some kind of reaction. And most of those will be real. They won't be psychosomatic, they'll be real. And so that's the simple answer. Then the second question I get asked is, what are these reactions likely to be? What do the clinical trials tell us? So you can see Pfizer in blue column, Moderna, and J&J. And in the yellow columns are vaccines that have been on the market that most of us have received one or more of those over the last 20 years or so. Pneumovax, the shingles vaccine, the hepatitis vaccine, and our flu vaccine. And if you read across, you will see that quite a number of people are going to feel pain in their arm after they've been injected. A needle went in and about 10 drops went into your muscle. There may be some redness in a few people, swelling, arm movement. That discomfort when you move an arm is going to be there. Systemically, there's going to be about 50% of us are going to feel a little bit of fatigue that day or the next day. These, by the way, are all transient, local, and systemic reactions, usually 1, 2, maybe 3 days. You're going to feel you might feel a little bit of fatigue. You might have a headache. Again, 50, 60%. Muscle pain, 50, 40%. And a lesser extent, chills, joint pain, fever, or even GI upset. And so how does this compare with our vaccines that we've had? Very, very closely. The comparison is very close. So if you've had a vaccine and you've had a local reaction and it went away in a couple of days, then you might well experience the same thing with one of the COVID vaccines. In the last slide, let's look at the benefits. We can really group the benefits into 2 areas. Personal medical benefits. That 95% decreased risk of infection is really high, 72% with the J&J vaccine. You're going to be at very low risk if you're in that 5% or that 28% that does get an infection, very low risk of serious reactions and death. The protective efficacy goes across the board by age, gender, race, or ethnicity. The people that set up these clinical studies did a wonderful job of enrolling various groups of people in there. And we know that protection goes across the board. The possible or likely protection from emerging strains And of course, there's reduced personal and family stress. But many people look at the altruistic benefits more than they do the personal benefits. You're less likely to transmit and infect family, friends, healthcare workers. You're going to decrease the emergence of variants. We know the variants come out of people who are infected. Less people infected, then less likely to have any variants later on. You benefit society and you add to the general trust. So between the personal and altruistic benefits, these need to be weighed against the personal and societal risks. With that, I thank you.
Thanks, Mike. That's excellent. That's a lot of good information, especially I like the comparisons to the other vaccines that a lot of people are very familiar with. One thing that you mentioned is the whole idea of these emergent strains or variants, as they're also known, which kind of leads us to our next bit that we're going to talk about. And I'll go back to Ryan here, because these COVID variants are in the news a lot now: British, South African, Brazilian. So I'm going to shift now and let Ryan talk a little bit about kind of basically what's the deal with the variants.
Sure. So just going back to my key and gate metaphor here. So again, mutations occur a lot in RNA genomes as they are replicated more frequently than DNA is mutated. And so this is just an illustration of, if we take the analogy of a physical key being like the spike protein, right? If you change the pattern of that key, so in the physical key, imagine, filing down one of the notches, that potentially, well, it has a few potentials. First of all, host shift. So I already mentioned that, that a change to the pattern of the key, the pattern of amino acids, specific amino acids in the protein can cause a host shift so that a previously uninfectable host, if uninfectable is a word, is suddenly a potential host, a new species, right? But then, and this is more related to the variants, once a particular virus is able to infect humans, right? There are still going to be mutations. There's nothing that's going to stop those mutations. And so as a result, there can be even more fine tuning. To beat my analogy to death here, we're all familiar with some locks where you have to jiggle the lock and jiggle the door and everything just to get it open, right? But it opens it, right? What if you could change just a little bit the key, right? That would potentially allow a much easier opening of the door. And if we take it from the analogy, that would be increased transmissibility, okay? It provides a tighter fit to the ACE2 protein, which again is a human protein. And next slide. So if you just focus on the upper left-hand corner there, first of all, what we see there is each row is a part of the sequence of the SARS-CoV-2 spike protein. So those letters are shorthand or are abbreviations for the 20 amino acids that make up proteins, right? And the top row, which is labeled reference sequence, Lauren mentioned earlier that we got a genomic sequence very quickly. So there was one that was sampled from a patient in Wuhan way back now in late December of 2019. That is the sequence to which we compare all other sequences that are sequenced around the world from patients. And the first one that I'm showing there, which is labeled D614G, right? So if you look in that column, the green column, Rich, sorry, to the left, right there, yep. No, sorry, to the left, Rich. Yeah, so that right there, yes. So the reference sequence has a D, which is stands for one of the amino acids. And very early on in the pandemic, the G variant, this is not specific to the UK variant, this change to a G was shown to make it more transmissible. The key was fine-tuned, it fit the lock better, right? And that is true of the vast majority of SARS-CoV-2 sequences around the world. But then if we focus on the alignment of sequences on the right, at position 501, the 501st amino acid of this SARS-CoV-2 spike protein changed from an N to a Y, right? So you see all those UK variants that I pulled out of a database, they're all Y, and the reference sequence, and in this case, most other sequences of genomes, of viral genomes will have an N there. And that too has been experimentally shown to fit better to the ACE2 protein and increase transmissibility. And so where it says N501Y and it points to that hot pink square at the bottom there, that is the very amino acid in the spike protein that has changed. And that small change enables it to fit the ACE2 protein better, right? So all of this has to do with transmissibility. And so there are many more mutations than just the two that I've shown here, right? That define the UK variant or the South African variant or the one that's in New York City, et cetera, right? But that all has to, we know that they're more transmissible, right? And that leads to more downstream hospitalizations, it leads to more downstream deaths, right? But a real concern is whether or not the other proteins of the viral genome will mutate, ones that don't just make it more transmissible, but that make it more virulent, make it more deadly, right? And that is a real concern. So that's one real concern, that there could be a mutation that would not just increase transmissibility, but would increase death rate, essentially, right? The other big concern is, as already mentioned by Mike and others, is it going to reduce the efficacy of the vaccine, right? And I believe that Chris is going to speak more to that, but just very briefly, you know, there is the possibility there, and in fact, some studies have now shown increased or decreased efficacy against these new variants. Bottom line, the variants are due to mutation. They're happening all the time. The ones that happen to work really well from the perspective of the virus, right? Those are going to start to proliferate and replace the old strains because they're more transmissible. That's all I have.
And I'll let Chris continue here. And the more people that get infected, the increased rate with all of this also, right?
Mm-hmm.
Yeah. So Chris, I'll let you add a little bit.
Yeah, and so like Lauren said, like Ryan said, like you just said, Rich, basically viruses can't mutate unless they're in someone replicating, right? And so the more people we let them into, the more sort of lottery tickets they can buy, is the way I like to think of it. Most mutations don't help. Most mutations are neutral or harmful to the virus, but some of those lottery tickets pay off, right? And so these are the three variants probably most people have heard the most of. We have the UK variant, we have the South African variant and the Brazil variant, and they have these different names. All three of these actually have those two mutations that Ryan was talking about, the N mutation and the D mutation. Some virologists call this Nellie and Doug. They have cute names. It's kind of interesting, but the naming thing with these are kind of challenging. And so if you want to go to the next slide here, Rich. And so I think that one of the biggest questions we get, and so Ryan touched on the fact that this makes them more transmissible. That's pretty well established. In fact, I think just yesterday, a group announced that in some of the sequencing they've done, like 50% of infections right now in several southern states are the UK variant. And so it will probably become one of the more common. But one of the things people then want to know is, well, what about the vaccines? Will the vaccines protect still against these new variants? And this data is coming out as we speak, just very, very rapidly, very frequently. This paper was just published last week. There's also lots of preprint data out there. I could share 10 different studies with you, but I picked the one that I think is the best. And when we look at this one, what you can see in this area I circled is we're comparing that reference viral sequence to this UK variant, so-called B117. And this is the one that is much more transmissible. It fits that lock a lot better. But what we're seeing in these graphs is this is looking at antibodies from people who have gotten the vaccine and whether or not those antibodies from those people will still neutralize these viruses. If you take these viruses in a lab and you give them the antibodies from people who've been vaccinated, does it help block them? And it looks like, as you can see here, the UK variant B117, it looks like it's just as good at blocking them, okay? And that's been pretty repeatable in most studies that I've seen, is that B117 from the UK variant, our vaccines neutralize that really well. So if you want to go to the next slide, Rich. And so now what about the South Africa variant? What about the Brazilian variant? B1351 and P1, so-called. So they're just named after the countries they were first sequenced in. So sometimes I hate to try to blame the country because they probably were in other countries potentially. But what you can see here is that the South African variant does seem to decrease how well neutralization works. But a real key component to look at here is that dotted line. That's called the limit of detection. So you can kind of think of that like 0. If something's down by that, that means, wow, we're really knocking them out completely. But look how much higher they are, right? And these are still levels that are pretty decent. And so I think there's lots of reason to believe that these vaccines are, maybe they'll lose some efficacy against, say, infection. Maybe some people will still get infected, but I think there's lots of reason to believe fewer people will, and that severe disease will still be prevented pretty well based upon the fact that there's still quite a bit of antibodies here, still binding to these variants, and they still are around. One of the other points that I need to make as a certified T cell nerd, and so in the immune system, T cells are another type of cell, and they're one that people don't talk about very much, but these vaccines give really good T cell immunity as well. And that's just harder to measure than antibodies, so you don't see near as many people talk about them, but there's been studies showing T cell immunity still exists for all the variants. And so while it might not, again, keep you from having the virus get into and divide a little bit, it will certainly help protect against severe disease, I think. So I think there's lots of reason to believe these vaccines are still going to be pretty efficacious, like certainly against severe disease. If you want to show the next slide, Rich. But one of the real great benefits of this technology, the mRNA vaccine approach, is if you look at the date of that underneath that headline that says March 10th at 4 p.m. That was yesterday. That's how fast this stuff moves, right? And so Moderna has actually already started injecting people in a trial to see about boosters with this new sequence for that South Africa variant, to say, hey, well, even if it evades, even if it knocks down that efficacy some, we can boost with the new sequence and hopefully get that same level of protection again. Thanks.
Thank you, Chris. So next, I'm gonna move to Lauren right now, and let me rearrange myself. Sorry. So I'm gonna stop the share. So Lauren, there's a lot, we're talking a lot about different people getting the variants being produced, and Jeff mentioned a while back from the health department about just testing being down, but testing centers are still operating. And can you speak a little bit to the importance of testing, and can you address developing immunity from the vaccine versus from the disease?
Yeah, so as we've heard, there are still daily cases both in our county, and I think I've seen like 40 to 50,000 cases nationally of COVID. There are still some hospitalizations and deaths, unfortunately, but we are getting a lot better. So we're definitely, on a downward trend, but most of our populations in most of the places are unvaccinated. We're working on it. We're getting better and better. We're getting more and more vaccines, but most people are still vulnerable. So catching cases early and catching people who are potentially harboring or spreading the virus is still important to protect all those people who haven't gotten a vaccine yet. And as we just heard, the more hosts you have, the more chances for variants to emerge. And that could potentially hurt our vaccine efforts if our variants start changing even more. Thankfully, the variants that we have are still pretty good at, well, the vaccines we have are pretty good at protecting against these variants. So we're doing a good job, but it's definitely still at a point where there are enough people around who are still getting sick that we can't just resume kind of the normal that we had prior to March of 2020. And the final thing is that the vaccine's not 100% effective. Even 95% means, 1 in 20 people could still get sick. And that protection is really great, but if there's still a good number of people in the community who could be spreading or sharing the virus, some of those people could still be at risk of getting sick. So if we can get our vaccines up and then our numbers down, that together would provide enough protection that we can start lifting some of the restrictions that we've had. And then the other part of the question about immunity, like I said at the very beginning, and we've heard multiple times, that people kind of react differently to the infection. And so some people have strong immune responses to getting a natural infection, but some people don't. And so you may have tested positive, but if your immune system didn't kind of ramp up and have a big response, your immune memory, so that the ability of your immune system to remember what the virus looks like, might not be very good. And so even if people tested positive, we're still asking that they get vaccinated so that we know we're giving everyone a dose that makes your immune system definitely turn on and definitely remember what it looks like. And then we can basically be sure that you are protected to that, 95 or 78% efficacy that we want. So that's why even if you maybe had COVID last year, it's still a great idea to get your vaccine to get the full protection for yourself and your community, as we heard.
Thanks, Lauren.
Thanks.
So we're looking at time and we're running a little short on time, and I want to be able to get to some questions, but I did want to bring it back to the community piece for a second and just ask Jeff Kindroy from the health department, just you guys have a lot of efforts that you've been trying to get a lot of shots in arms. So what have been some of the challenges with vaccine distribution so far, and what's the latest there?
Sure. Well, probably the most obvious is the supply does not meet the demand. And, we have a lot of capacity in Grant County to give shots, but we're just not able to get enough vaccine. For example, for the week of March 15th, we ordered at the health department alone 2,500 doses to try and give, and we're getting 200 doses. So although it's a little disappointing, that's one of the challenges that we face. We've had some weather issues and shipping delays. Now, hopefully, as the weather turns, that'll be less issues with that. We talked a lot about storage issues with the vaccines. When we store our vaccine, they're in refrigerators that are monitored with data loggers, alarms, generator backups. We really want to protect the vaccine itself. Another thing that's is difficult with the vaccine is if you transport it. It can only be transported for a little bit in its thawed state. When it's shipped to us, it's shipped frozen because the frozen state protects it. But once it's thawed out, you're limited to 8 to 12 hours of time in transit, or the vaccine risks becoming too damaged to be effective after that. Once you open a vial, you have 6 hours to use it. And sometimes when we open vials, we get 10 doses out of Moderna. Sometimes we get 11. A lot of it depends on the different supplies that are shipped to us as to whether the needle is efficient at drawing up the vaccine and administering it completely. And there's challenges when we administer 11 doses and for first doses and we get a different set of needles or syringes, I should say, the second time around, and we don't get 11 doses as frequently, and making sure that we have enough vaccine to cover all our second doses. In addition to that, there have been some shortages in ancillary supplies, although they haven't been severe yet. Things like sharps containers, and other things are becoming a little bit more difficult to come by because of all the vaccination that's going on out there. Then there's other challenges like the fact that we live in the corner of our state and we border 2 other states which have different eligibility requirements than us. So there's different vaccinations of different eligible populations going on at times. So to combat this, we work with our partners very closely. We meet twice a week with our vaccinating partners to figure out what we're getting for vaccine and how we can best use it to vaccinate the most currently eligible populations and not losing track of people that were previously eligible. And we've been quite successful in doing that. Our percentages of getting the individuals 65 and older done quickly exceeds the state average. We've done very well with that. And we were able to largely do last week most of our K through 12, and we're currently working on higher learning. The quicker we can get through eligible populations, the quicker we can get on to others. So that's exactly what we're trying to do is to work together with our hospitals, our clinics, our pharmacies to get people done quickly.
Thanks, Jeff. So I think what I'm going to do now is shift to just some of the questions that we've been getting, just looking at time and wanting to get a few of them. And one question that I'll read one of the first ones that I see here. So one of the folks watching said, I received my first dose of the Moderna vaccine and had no ill effects. Should I be concerned that I got a faulty vaccine? My Shingrix vaccine left me mildly ill for a day. Does anybody want to address that, Mike, maybe?
Yeah. Yeah, you're in the lucky 20 to 35%. And but you may see a reaction on the second because reactions are higher in the second dose. The data I showed you was in the second dose. And reactions can be a little higher with any vaccine. And while that Shingrix vaccine is a fantastic vaccine, 95% efficacious, you could see in that column that it also is high on reactivity.
Thanks, Mike. We've been doing a lot with like surface cleaning and maintaining and making sure that we're cleaning surfaces after we use that. But what's the latest on the value of that, I guess is the way to put it. Anybody have any research that they've come across or read on that? I mean, I know what the guidelines are stating. I'm just wondering if there's any ideas there. Yeah, go ahead, Jeff.
I'll speak a little to that. Part of it depends on how likely an object is to be contaminated as to how much it's going to benefit from cleaning. So in situations where there's coughing and sneezing going on or high touch surfaces, or if there's a lot of exertion like in physical activity for sports or working out, objects can be contaminated with respiratory secretions a bit easier. So using common products that kill viruses works pretty well. But the general thought is that most of the transmission occurs through exposures to infected individuals. So we're less concerned as we've learned more about exposures due to objects, but it is possible that you could get a contaminated object and become infected, get enough of a dose. But respiratory concerns, and that's why we practice masking, social distancing, and worry about those things even a bit more than other things.
Okay. Well, thank you, Jeff. And unfortunately, hopefully those of you that have joined us and been with us for the last hour and a half have gained some information. And my dog is happily barking. But I'm going to turn it over to Wayne right now to kind of give some final words and final thoughts here. But I just wanted to give a quick thank you again to all our panelists for participating today.
Well, my thank you in closing is really fast. So we can probably squeeze in one more, Rich, if you got a quick one.
Okay. Well, yeah, there was one question that did come up, and maybe one of you can address that. That was related to the utilization of embryonic stem cells in in the development of some of the vaccines. And I was wondering if any of you are willing to address that. I think, Chris, are you? Yeah, go ahead, Chris.
Yeah, so I actually think that the usage of embryonic stem cells in the vaccines is not actually a correct statement when it comes to the mRNA vaccines, Moderna and Pfizer. They did not have any embryonic cells used in their production. In fact, it's a little picky scientifically, but embryonic stem cells are a different thing than, say, a fetal stem cell, a fetal cell line, I should say, excuse me. And so I think probably what's going on is someone has misinterpreted or a website has not stated it properly, but the Johnson & Johnson vaccine during its production utilizes a cell line called HEK293, I believe. And it's one that's been around since like 1970. So it does use cells that originated with with aborted fetal tissue, but in 1973 in the Netherlands. And those lines have been used for a long time since then. And essentially, you know, they have like 60 chromosomes. And so what they are and why they're used is they're used as a packaging line. So they package the virus and they're extremely good at it. And they package the vaccine, I should say, the adenovirus-based vaccine. They package it and they're extremely good at it and nothing else is as good. But that's for the Johnson & Johnson that utilizes that. Moderna and Pfizer did not use that and did not use embryonic stem cells either.
Thanks, Chris. So Wayne, I think maybe it's time for Wayne. So I'll turn it back to Wayne. So thanks again to all the panelists for the help. And we did have a few more questions that we just simply didn't have time to answer, but I appreciate all of your attention. Thank you. Yeah,
and so agree. We're about out of time. For attendees, I hope you found this insightful and informative. From my standpoint, wow, just incredible panel, incredible information. And so again, I want to thank our panelists for your valuable time and expertise. I would be remiss if we didn't thank and recognize Dr. Amanda Trewin, who's the biology department chair, and she's been facilitating things in the background. But actually, she was the one that had the idea to have this panel in the first place. And so we have to, hats off to Amanda. I also want to thank everyone who helped put this together and marketing, get it out to folks, things of that sort. Of course, thank you to Rich for being the host with the most, right? And finally, I want to thank our audience for joining us. As we like to say here at UW-Platteville, in closing, I just want to say, be safe, be strong, be pioneers, and thank you very much, and have a great evening.